the first-line treatment of common EGFR mutations, exon 19 deletion and L858R mutation-positive advanced non-small cell lung cancer, for the last, I would say, 5 years or so, has been treatment with third-generation EGFR TKIs, such as Osimertinib. And with drugs like Osimertinib, we see a median survival of approximately 3 years. Based on estimated real-world data, the 5-year survival is less than 20%. In addition, about 25 to 40% of these patients who are treated with third-generation EGFR TKIs don't go on to receive subsequent treatment. So both these data sets highlight the need for improved first-line treatments with improved efficacy. So it was in this regard that the MARIPOSA study was conducted, which evaluated Amivantamab, EGFR MET bispecific antibody with immune cell directing activity in combination with the third-generation EGFR TKI, Lazertinib. The initial results of the initial analysis were presented at ESMO last year and subsequently published in the New England Journal of Medicine. And it showed that the combination of Amivantamab plus Lazertinib demonstrated a significantly improved progression-free survival compared to Osimertinib with a hazard ratio of 0.70. Based on the results of the MARIPOSA study, the US FDA recently approved the combination of Amivantamab plus Lazertinib for the first-line treatment of common EGFR mutation-positive advanced non-small cell lung cancer patients. So at this year's World Lung, we presented the results of a longer follow-up with a median follow-up of 31.1 months from this study. And what we focused on in this presentation were endpoints of intracranial efficacy, endpoints of post-progression outcomes, such as time to subsequent treatment, time to treatment discontinuation, and progression-free survival too. And of course, also presented results on overall survival. And what this longer follow-up showed is that as far as intracranial efficacy is concerned, intracranial progression-free survival rates were increased with Amivantamab plus Lazertinib, with the 3-year intracranial progression-free survival rate of 38% as compared to 18% in patients treated with Osimertinib. In addition, even though the intracranial response rates were identical at 77% in both arms, the median intracranial duration of response was not reached with Amivantamab plus Lazertinib, whereas with Osimertinib, it was 24.4 months. Interestingly, at 3 years, among patients who had intracranial response and were treated with Amivantamab plus Lazertinib, 51% of those patients at 3 years continued to demonstrate intracranial response, whereas that percentage was 0% among patients treated with Osimertinib. In addition, post-progression endpoints of time to treatment discontinuation, time to subsequent treatment were prolonged with the combination. When it came to progression-free survival too, defined as time from randomization to progression on subsequent treatment or death, was prolonged with Amivantamab plus Lazertinib. At 3 years, the PFS2 rate was 57% with the combination and 49% with Osimertinib. And then finally, at a median follow-up of 31.1 months, there was a promising trend in overall survival favoring Amivantamab plus Lazertinib compared to Osimertinib, where the median survival was not reached with the combination and was 37.3 months with Osimertinib. What was also interesting is that these overall survival curves tend to diverge with longer follow-up, in that at 2 years, the survival difference was 5% of 75% versus 70%, was as compared to at 3 years, the survival rate was 61% with Amivantamab plus Lazertinib and 53% with Osimertinib. So I think what this longer follow-up shows is that the combination of Amivantamab with its different mechanisms of action in combination with Lazertinib improves several different outcomes as compared to Osimertinib in patients with common EGFR mutation positive advanced non-small cell lung cancer. And I think that with the recent US FDA approval and with this longer follow-up, it becomes another option for the treatment of these patients and should be involved in our discussions with these patients in coming to during the shared decision-making process.